starting on the bottom of Chelsea's page with the constrictive pericarditis, and it's where the ventricles become non-compliant and they don't fully relax, and so you have a limited diastolic filling, so you've got less volume. Nope, I have that wrong. Anyway, your diastolic filling is limited, and since they can't squeeze, the fluid backs up, creates back pressure on the ventricular or peripheral circulation, and then the ventricles compensate by becoming thicker. Over time, this can improve systolic function. Over time, it impairs systolic function. There we go. Then acute pericarditis is usually just a result of inflammation. And then next on the page is the couple graphs. I ran out of room, so the blue represents acute pericarditis, and the green is for constrictive. So, I mean, I can read through all these causes if you want, but some signs and symptoms that I thought were interesting and that we haven't touched on for constrictive pericarditis was the pulsus paradoxus, and that's why your systolic blood pressure decreases greater than 10 millimeters of mercury on inspiration. Apex says it doesn't happen very often, but I thought it was interesting. You also get the Kussmaul sign, which is an increase in CVP and your JVD on inspiration. You have an increase in case pressure, arterial distension, which causes dysrhythmias in the pericardial mock. I had to look this up, so excuse me just 1 second. Let me find the page. And it says it's a highly pitched early diastolic sound that occurs when an unyielding pericardium results in sudden arrest of ventricular filling. So, and then the causes of constrictive are cardiac surgery, cancer, specifically radiation, RA, TB, and uremia. The treatment is a pericardotomy, and then for the anesthesia management, you want to avoid bradycardia because your cardiac output is dependent on your heart rate. You want to maintain your afterload, maintain your heart rate and contractility, and avoid positive pressure ventilation because that can also decrease your venous return and your cardiac output. Then causes for acute is infection. Most common is viral. Then you have Dressler syndrome, which is inflammation from necrotic myocardium from an MI. You can also get acute from RA, lupus, scleroderma, and trauma. Some signs and symptoms are increased pain with inspiration, and postural changes. To alleviate that, you can either lean forward or lay down. You've got a pericardial friction rub, some ST elevation, but your enzymes are normal, and a fever. Some treatments for acute, they usually resolve spontaneously, but you can give salicylates, oral analgesics, or corticosteroids to help with pain. And then there weren't any anesthesia management listed.
All right, so I'm just starting with cardiac. So,
during surgery, so it allows the surgeon to operate on an immobile heart. It does the same things as our lungs, so it goes to an oxygenator that gives oxygen and removes CO2. The venous line is hooked to the inferior vena cava or superior vena cava. It goes to the reservoir, which then goes to a pump. The pump is either a roller pump or a centrifugal pump. The roller pump, it kind of squeezes the blood through the tubing. The centrifugal pump is just spinning super fast. ECMO is a centrifugal pump, yeah. With the roller pump, if the aortic line, so then it goes from the pump to the O2 oxygenator and the heat exchanger through a filter and then back into the aorta. So if the roller clamp, if this arterial line was to be clamped, this would still continue to pump, and it could rupture the arterial inflow, that tubing. The centrifugal pump is preferred. If you have a high afterload or if this arterial line gets clamped, blood will back up into the venous circulation. There is risk with the roller pump to get airflows if the reservoir goes empty.
So make sure they are meticulous on getting bubbles out of all these lines.
But they have perfusionists that run that pump. So.
Yeah. Okay. So let's assume you're on cardiac bypass. Do you have to ventilate? No. So you don't have to ventilate. What if you're on sevoflurane and you're not ventilating now? They add it. I don't know if a lot of you guys knew that. They have a sevo. It's usually sevo, not always sevo, but they have a vaporizer on their machine. So when we stop ventilating and they start on bypass, they'll start using their vaporizer. The other thing that's good to know as a student.
So then what's your job?
There are people, a lot of docs that will walk out of the room at that time. And this is right where I was going with what I was going to say. Some of the perfusionists will start their own phenylephrine drip because they want to maintain that perfusion pressure, which is a flat line, but they want to maintain it, in the 50 to 70 range. And so through phenylephrine, they'll maintain that perfusion rate. That's kind of like your mean blood pressure, right? When you got non-pulsable stuff. Well, they'll control that, and the perfusionists are controlling that. Some of the docs will get up, walk out of the room. They'll give Versed and Vec still in their IV to make sure that they're kind of scrambled and paralyzed that way, but everything else is done perfusionist. So if they get Versed and Vec, and they look at their watch, I've got 30, 40 minutes, depending on how long the perfusionist gone. They may walk out. As a student, you guys won't do that. You guys will be in there and watch. But they do the vaporizer, they do the phenylephrine. Some perfusionists won't do the phenylephrine, so you've got to run a phenylephrine to maintain the perfusion pressure. So you just got to communicate with your perfusionist to know that.
Do you have any peep to your perfusion lung just to keep?
Usually not. Usually you totally disconnect the circuit, set it to the side. There are case studies where they came off pump where they forgot to ventilate. And like 10 minutes later, the surgeon's like, why is our blood so dark? And you realize, oh crap, we have a ventilating containment. There are case studies that they forget to ventilate. So it's important for you guys when they come off bypass to start ventilating.
Because you don't want those lungs inflated at all. That takes.
Yeah, and when you inflate them, you don't just connect and flip your vent on. You actually do a slow manual inflation, kind of a small, a medium, and then a big biocapacity breath to get them re-inflated and big. And you'll see them come across the chest. Well, as the chest is open, you'll see them kind of do this as you inflate.
How do we deflate them? So you talk about the single tubing that just have one lung. How do you do that?
Gravity just usually does it. You just disconnect it, leave it, and gravity will just fall down.
That's cool. So you disconnect the circuit so that you don't, when you go back, you're not thinking you're ventilating when you're not.
Yeah.
That's
Well, because I mean, it's not necessarily terrible for you to be ventilating while they're on bypass. I mean, it's overkill because they're getting oxygen in their perfusenists. But the surgeon is gonna be like, I can't work with the lungs like coming up. They'll come up touch, they'll go down. And he's like, I can't work with it, so you gotta get them down.
crazy. This is the perfect one for you guys.
Yeah, I like this. Anything else? Okay, moving on. We got 2 left.
Thanks, Jay.
And then before you guys take off, I got a couple of announcements.
Okay, so continuing on with cardiopulmonary bypass, we have already hit on it. Don't have to worry about oxygenating them because there's an oxygenator similar to ECMO. There's a membrane that's the preferred way to do it, but it does cost more money. Then there's also a bubbling technique that's not as effective, but you can do that because it's cheaper. There's also a heat exchanger as part of the cardiopulmonary bypass machine that warms the blood, keeps the patient, or cools the blood.
Or cool, that's what they're going.
Just because, I mean, you want to slow down oxygen consumption, metabolic demands, cool them off. They'll get it like down to 32.
For some cases, they'll go Waco. They'll do circuit arrest is what they call it. I don't know if you guys have heard that term. They'll do circuit arrest, and they will take that Waco down to probably the low 20s. I'm trying to remember. I can't remember. It's been a while. They'll pack their head nice.
Yeah.
They'll have the CMRO2 monitors on, and they'll literally not perfuse out there. They're working on a dead patient, right?
Yeah.
And at that low temperature. It's like the same thing, kind of the same theory when you hear about drowning victims. You don't pronounce drowning victims dead until they're warm and dead, as opposed to cold and dead, because that cold can preserve. Sorry, those are usually big aortic valve and root cases where they got to reimplant coronary arteries.
I just need to throw ice in the chest
Yeah.
before.
Yeah, they do, and they'll still do that just on cabbages. They'll throw ice in the chest and cabbages. Okay, sorry, go ahead.
Priming the bypass circuit, it's preferred to use blood because then we don't have decreased hematocrit, oxygen carrying capacity, decreased blood viscosity, decreased concentration of our drugs and plasma proteins. But you can prime it with a balanced electrolyte solution, which is mannitol, albumin, heparin, and bicarb. But then you will get all of those side effects of priming that system with that instead of blood. Pre-bypass awareness for the patients, the most common is during sternotomy and rewarming, so we want to make sure that they're deep. And then heparinization is based off of activated clotting time of greater than 400 seconds. If they're allergic to heparin or have HIT, then you can use some of these other factor 10 inhibitors to also, anticoagulate the patient.
Okay, couple things I want to mention. Pre-bypass, has anybody ever heard of them taking out whole blood? Like after they do put their central line in, sometimes they'll hook a blood bag up to the central line and drop it onto the floor for gravity to fill it. What's the advantage of doing that? Taking out whole blood? Sorry, too many people.
Oh.
Okay, you're going to give it back to them, but what's the advantage of having whole blood?
Let me turn you around.
Clotting factors. What is clotting factors? Clotting factors. Tears them up, right? Reduces them, breaks them down. That's why post-cardiac patients can tend to bleed. They need all those clotting factors. That's why you're doing FFP, cryoplatelets, and all those kind of patients. Okay, that was the first thing. So some people, depending if they've got what their starting crit is and how, their blood factors are going to, they may drop a couple of bags of whole blood and then store it in some ice and keep it during the case. And then after they come off, they'll give that back to them for all those clotting factors out there. The other thing I wanted to mention was, sternotomy. So you will find during sternotomy, and sometimes the doctor won't tell you. You'll hear the saw kind of like this. But when they go to do the sternotomy, always drop your lungs again. You gotta drop them, especially if it's a redo. What's the issue on a redo sternotomy?
You're cutting metal.
Scar tissue. So if it's scarred up against there, and this necessarily isn't a lung issue. Now we're just talking about what's the issue. If it's that the heart's scarred up against the sternum, and they go to cut through that, what's when the way the heart's placed in the chest? What part of the heart are they going to cut through if it's scarred up and they soften the heart? And I've seen this happen. Left ventricle. Left ventricle. That's when they crash on the bypass. Within seconds, they're throwing in any lines they can and getting it on. They basically got a couple minutes to crash. So it's always good to be attentive during sternotomy. You always drop the lungs so they don't actually go through a lung. And then the other thing is that the redo, you want to be aware because it happens, unfortunately. I don't remember, to be honest with you. It's been too long ago. But
Do they really prime the entire line with mannitol?
well, it's a mixture. It's a mixture. I mean, obviously they've got a lot of volume, or a lot of tubing. That it's big tubing and it's a ton of lines. So they got. I mean, because you can't have air in there. They're very meticulous getting air out. So they use between blood, mannitol, a lot of things that he mentioned.
So it's not just like one soul. It's like we're not throwing this entire thing to mannitol.
No.
No, it's mannitol, albumin, heparin, and
What
bicarb.
is it?
Oh, that's a combination.
So it's just like it's a quote balanced salt solution.
Yeah. It's not one of those things. It's a multitude.
Is it like 250, 500 a liter?
Ask a perfusionist when you do a rotation. I don't know, but when you think of all the large tubing that they have coming out of the chest, it's got to go about 4 to 6 feet away. Then you've got all the cylinders that they got to fill, the centrifuge or the rollers, and they might have 2 or 3 of those running, and then it's got to go back up to the patient. It's a lot of volume.
Okay.
So you'll go through the A line, and once they go on bypass, usually the perfusionist will be doing the left and doing their checking their body. One more.
All right, aortic cannulation. During aortic cannulation, we want to avoid hypertension. It's important to keep your SpG lower than 100. The ideal range is 90 to 100 with a MAP of less than 70. You want to conserve blood because there are risks to blood transfusions. So you
That's
can
the other advantage to the pulling blood too, right? It's their own blood.
so you can use the antifibrinolytics, the amino caproic acid or the tranexamic acid.
Tranexamic.
Tranexamic acid.
Amicar is the other name that's shorter for the.
And then you can use the cell saver as well.
They do all those, not all of them, either Amicar or tranexamic acid.
So for when they're on bypass, they do the cardioplegia. And our main goal is to reduce myocardial damage during this time. We can do antegrade cardioplegia, but you have to have a competent aortic valve to do that. The way they do that is by injecting a potassium solution to arrest the heart. And then to reset the heart, we use warm blood when we're ready to do that.
You can wash that cardioplegia out of the system.
So this right here, this comes under our blood gas management. So we want to avoid hypothermia. Well, they sometimes do hypothermia, but we need to be aware when they are hypothermic that you are increasing the ability for CO2 to diffuse into the blood. So it's going to alter your blood gas. So you need to be aware of that. These are the 2 different ways to check your blood gas. The alpha stat, A is for adult, so it's better to check the adult blood gas. And then the pH stat is better for pediatric blood gas. So with alpha stat, it doesn't correct for the patient's temperature. And the aim is just to keep the intracellular change neutrality across all temperatures. And then with the pH stat, it's a constant pH across all temperatures. And like I said, it's better for peds. So key points for all this. So we have the non-pulsatile flow, like Ted had mentioned already. So we use our MAP for our blood pressure. And there can be full bypass, partial bypass. So just be aware of that. And then they can also do a left ventricle vent, which removes blood from the left ventricle. And then there is I forgot to write this on here, but when we do a cardiopulmonary bypass, the patient is at risk for systemic inflammation, which can lead to organ damage or failure. So be aware of that. And because these patients are heparinized, we give protamine to reverse them. So protamine forms a complex with the heparin. The dosing ratio that they have here on Apex is that 1 milligram of protamine will reverse 100 units of heparin. And then this one, so it depends on the dose given, I believe, but it says if 30,000 units of heparin remain in the patient's circulation, then the calculated dose for protamine is 300. So, and there's 2 ways of calculating your protamine dose. You can calculate it based on how much heparin you gave them at the beginning of the case, but that may lead to overdosing or giving too much protamine. So it's best to use the predicted to remain in the patient's circulation. And I don't really understand that. Maybe Ted can talk more about that.
I don't know either. I'd have to look it up.
Okay. But there are some complications to protamine, some of the side effects. It actually causes anticoagulation too. So if you give too much, they're going to still be anticoagulated. And you're reversing the heparin, but still making them anticoagulated. But it can also cause systemic vasodilation and pulmonary constriction. And you want to give protamine over 10 to 15 minutes.
You always start with a test dose because it's a very, I don't remember if it releases histamine or not, but people can be very allergic to have vasodilation, detrimental post-cardiac. Always start with a test dose. Whether you're using it, just giving 50 milligrams in the cath lab or you're giving like a 300 milligram dose here, you're going to want to start with a small test dose, wait a few minutes, see how they, I had one case after I graduated, I stayed back with working in cardiac call that we gave, and they suspected this back to the protamine, but we gave the protamine dose, and within 5 minutes, that this patient, literally, blood turned to jello throughout their whole body. They did not survive.
So that's just 10%.
Yeah, so it's just enough that you're going to get a response from it. So I would probably do 5 to 10 milligrams. So 1 to 2 cc's usually is 5%.
The other thing with giving it slow is the faster you give it, the more likely you are to cause anaphylaxis. Other key points during, I think this is overall during the cardiopulmonary bypass, your radial blood pressure may be falsely low. And it's not uncommon for patients to go into a heart block after you rewarm them and you restart the heart. So often they're going to come out with a pace.
Especially in what kind of surgical procedures? Basically, these are cardiac
Valve replacements, aortic valve.
replacements, yeah. Those get into the conduction system, so you'll see pacemakers all the time. So you got to be able to understand how to run a pacemaker. For those of you who have had much cardiac experience in these rotations, you got to get to know your valve or your pacemaker settings and understand synchronization, all that stuff. The thing I was going to say, don't make this mistake accidentally. Sometimes they use radial arteries for drafts for cavities. And if you throw an A-line in the radial artery that they need to take out, that's very frowned upon. And it probably occurs more often than not. So communicate where you should know before you even get in the room. Where are they hoping to pull the grafts from? Are they doing them, or are they doing saphenous? Are they doing radial artery? They're going to do radial artery. They already know. They usually have an ultrasound scan test done, but they already know which one they're going to take. All right, which one are you going to take? Which one are you going to prep out? Don't put your A-line in that.
I was going to say with the systemic inflammation.
Let's talk about, next we have aortic aneurysm classification. So, and just to be clear, as you look at this piece of paper, the first part talks about thoracoaortic aneurysm classification, and the next one talks about aortic dissection. So that's how this is broken down. So as you're doing your studying, remember we've got the classification of thoracic aneurysms, and then we have the actual classifications of aortic dissection. So don't get those two things confused. I'm going to give you the down and dirty version of this thing. If you look at the type 2 Crawford classification of a thoracic aneurysm, the type 2 are the most difficult, most at risk. I mean, the type 3 is also, but the type 2 is the worst. So somebody tell me why the type 2 Crawford aneurysm is the most difficult, most risky to repair.
Involves almost the whole thing.
Okay, thank you, Kim. It's a thoracic and abdominal. These pictures, I don't know if you guys printed color or if you did black and white. I wish the Apex guys would have done a little better job on, because if you're not looking close enough, it's kind of hard to tell, but you can see that aneurysm on the type 2 goes all the way up to where it starts to twist over. And you can actually see it over on the ascending aorta also. They have a little spot over there, so it could be there, might not be there. But it's on the descending thoracic, and it's all the way down to the abdominal, right past those renal arteries. So these are huge. So the type 2 is the most difficult. And remember that the Crawford scale just gives you the region of where the aorta is affected. That's what this is for. It's just a common thing where if somebody's back east versus on the west, they can say, hey, this guy's got a Crawford type 2 aneurysm. Most people that if you're familiar with it would then realize, okay, this is a big deal. We're dealing with thoracic and abdominal. So everybody's on the same sheet of music. And then it has the other breakdowns right there, which you can see on the chart compared to the picture. So the next part is the DeBakey and the Stanford classification of aortic dissection. And again, let me just point out that the type A Stanford and the type 1, type 2 DeBakey are surgical emergencies. And why are these surgical emergencies? Those of you that read ahead.
They involve the thoracic and the abdominal aorta.
No. Good guess. Not quite what I'm looking for. Not quite what's in the notes. What else?
Aortic valve is involved.
Aortic valve. Thank you. It involves the aortic valve. Often involves the aortic valve. And so if you've got an aneurysm that is up in the aortic valve, you're going to have some pretty significant aortic insufficiency and some problems there. And we all know your aortic valve is not doing well, then you aren't doing well. So these are surgical emergencies that need to get taken care of.
When you have an aneurysm that gets up into the valve, what else are you going to be concerned with that's in that area?
Coronary perfusion.
Coronaries, yep.
Good. Let's see. What else I want to talk to you about these. That does mention that descending aortic aneurysms are often treated medically as opposed to going in for surgery. And on the next page, we're going to have some different information as far as when things are usually treated. But just remember that aortic dissections require surgical intervention. If that starts to dissect, then it's time to go in and get this thing fixed. Next page, it mentions some stats on how often these things can happen to people and some different risk factors that go along with it. A lot of times when people get these things found, it's through something else. They just find a palpable abdominal mass and then it's diagnosed through other things to see exactly what's going on. It talks about how they're formed as far as the destruction of elastin and collagen and how things just start to break down and you have atherosclerosis, inflammation, blah, blah, blah. The main thing here is when you look at these aneurysms, it's going to be size dependent is going to determine how serious this is. And then if we go way back to first semester, I think we talked about law of Laplace because these aneurysms follow that law. Remember that if, and you have right here, it talks about wall tension equals transmural pressure times vessel radius. This just means that, and it's a difference if it's a cylinder versus when it becomes a sphere, right? So cylinder like our vessels versus a sphere like round. Okay, so if it's a cylinder, we're looking at tension equals pressure times radius. Okay, if we're looking at a sphere, then it's tension equals pressure times radius divided by 2. So comparing the two, a cylinder is going to have more wall pressure and a bigger chance of dissecting than this thing is a sphere. But eventually, if you have a aneurysm that's beginning to grow and it's becoming more circular, it's eventually going to exceed the pressure that the cylinder was, and that's why these things get so dangerous, because the pressure just continues to rise. As the vessel gets bigger, the pressures on the wall increase, and that's just by the law of Laplace. If you plug in numbers, you can see that. If you look at that chart, it shows you the risk of rupture, right? If it's less than 4 centimeters, according to this chart, the risk of rupture in percent per year is 0%. Alyssa, what was that sock puppet? Did I just see a sock puppet in the screen?
It's my son.
Oh, that was a shark or a snake. Oh, that's freaking awesome. So if you go down that chart, you can see that from 4 to 8, you go from 0% down to 50%. Okay, as the diameter of the aneurysm gets bigger, the chances of rupture significantly increase, and that is all based on the law of Laplace. And as the vessel radius increases, the wall tension increases. It mentions that the classic triad of a triple abdominal aortic aneurysm or an abdominal aortic aneurysm is hypertension, back pain, and pulsatile abdominal mass. And you can have had patients that come to the ER, we're transporting, that have this horrific back pain. No other symptoms, but just this all of a sudden the worst back pain they've ever had in their life, and they go and they're diagnosed with a AAA. And a lot of times AAAs, if they do start to bleed, they get patients that come to the ER, we're transporting, that have this horrific back pain. No other symptoms, but just this all of a sudden the worst back pain they've ever had in their life, and they go and they're diagnosed with a AAA. And a lot of times AAAs, if they do start to bleed, they get tamponaded off because of where they're located down. They bleed into the retroperitoneum, and that as it starts to bleed into that space, the pressure, because it's a closed space, will tamponade that off, and they won't, sometimes there's no numbers on this, but they won't die because the bleeding is stopped for a while because of the tamponade effect. And then myocardial infarction is the most common cause of postoperative death. And I think that's probably because if you go back up to, well, one, that's a significant surgery. And two, if you go back up to the independent risk factors, you've got cigarette smoking and advanced age are already on there. So you take that clientele and then you give them a AAA and then you put them through AAA surgery, and that's going to be a lot of stress on the heart. And so an MI is what's going to be the most common cause of a post-op death. Any questions on that? Now back to the radicular arteries. And I don't know if I'm saying that right. If I'm not, I apologize. I don't know how else I could say radicular. The most important is the artery of Adamkowitz. And the artery of Adamkowitz is the largest anterior segmental medullary artery. So you hear about things, if it's going to mess up the artery of Adamkowitz, that's because it's the largest one. And it typically arises from the left posterior intercostal artery at about the 9th to 12th intercostal artery area. And I just kind of took that stuff out of an anatomy book because I just wanted to see where that was at. So it comes off of the aorta basically, which makes sense because that's the majority of the circulation, right? And it supplies the lower 2/3 of the spinal cord via the anterior spinal artery. Let's see. You need to remember that the spinal cord is perfused at each segment, but not along its entire region, right? So it's like one vessel is feeding the entire thing, but it's segmental. So different, like radicular arteries will be feeding different spots. And then it talks about anterior spinal artery syndrome. So if the clamp is placed above the artery of Adamkowitz, this is where we can get ischemia to the lower part of the cord. And like we mentioned, the artery of Adamkowitz supplies to the lower 2/3. So if it gets blocked off, that's a significant part of the circulation that's going to be affected, and that can lead to Beck syndrome. And Beck syndrome, along with all other syndromes or things that we talk about, you're just going to have to figure out some mnemonic or whatever it is that you need to do so you can remember what this one is. And the 4 things that it talks about with Beck syndrome is that you get flaccid paralysis of the lower extremities, bowel and bladder dysfunction, you get loss of temperature and pain sensation, but it does preserve touch and proprioception. And then it breaks this down into the sensory tracts and motor tracts. So what I did to kind of help me with this is I went up to where it mentions, like, for example, flaccid paralysis of the lower extremities. Then I listed that it's the corticospinal tract perfused by the anterior blood supply, because I wanted to know which tract this was affecting. And the chart is great, but I wanted to know, as far as Beck syndrome, which things this did. So I'm just going to read to you, kind of list out what I did here for my purposes. So flaccid paralysis, like I mentioned, is the corticospinal tract perfused by the anterior blood supply. Bowel and bladder dysfunction is autonomic motor fibers perfused by the anterior blood supply. The loss of temperature and pain sensation is the spinal thalamic tract perfused by anterior blood supply. So those first 3 are all the anterior blood supply. And the preserved touch and proprioception is the dorsal column is perfused by the posterior blood supply. And that's why you have preserved touch and proprioception, is because that's the posterior part, not the anterior part. So those first 3 happen because I'm so sorry. Because we know that artery feeds the anterior part of the cord. So those 3 things are going to naturally happen because you have no supply. Versus the 4th one where it's posterior, so you're going to be okay. So that's how I broke that down. I think that made it easier for me to kind of wrap my head around that stuff. All right. Anesthetic consideration.